So you are all most welcome to this session where we are dealing with ART in infants and children. My name is Adiodata Kechitinwa, commonly known as Dr. Adi, and I lead the Bela Uganda program. I'll be chairing assisted by Dr. Dennis Tindiewa, and we are very happy and very excited to see most of you come here this afternoon. We have laid down 6 presenters ranging from ART strategies to ART outcomes. We will begin with having a presentation and then we'll have questions. I wish to request that we stick to 1 question per person so that we give a chance to other people to present. Our first presenter is none other than Michael Bovin. Michael is a professor who has pioneered neurodevelopment assessment at risk children in sub-Saharan Africa for the past 28 years. I have known Michael for a long time, and I knew him in this field, and he continues in this field. He's leading NIH-sponsored clinical trials research in Uganda pertaining to early childhood development training of caregivers affected by HIV. Michael, the floor is yours, and you have 10 minutes of presentation.
Thank you, Adi. It's a privilege to be here. In terms of a background to the study I'll share with you, although now triple antiretroviral treatment during pregnancy and breastfeeding for the prevention of mother-to-child transmission of HIV is the standard of care, the PROMISE clinical trial was specifically to look at whether there was risk involved neurodevelopmentally to the children and what the outcomes were for mothers in terms of prolonged exposure to triple antiretrovirals. Because of breastfeeding throughout many parts of the developing world, but in particular in sub-Saharan Africa, there was a more prolonged exposure of triple ARV, and our study was an attempt to look at neurodevelopmental outcomes at 2 of the PROMISE study sites, in particular Uganda and Malawi. And in order to be able to interpret the neurodevelopmental assessment data for the PROMISE children, we enrolled unexposed, uninfected comparison groups from their communities. And I'll be sharing the results of that with you. In brief, for the PROMISE study, mothers with HIV at the antenatal care clinic with CD4s of above 350 were randomized either to triple antiretroviral prophylaxis for PMTCT or else sudafedine. After birth of the child, during an initial nevirapine perinatal treatment period, mothers were once more randomized either to continue triple antiretroviral or else withdrawn from antiretrovirals, and instead the infants were on nevirapine throughout the course of breastfeeding, which for the majority of breastfeeding mothers was up to a year and beyond. We looked at neurodevelopmental outcomes at 12 months, 24 months, and 48 months using the Mullen scales of early learning, and then at 48 and 60 months using the Kaufman assessment battery for children, which provided for a comprehensive neurocognitive assessment profile. These are specifically, at that time, the standards of care with triple antiretroviral that were administered at the antepartum randomization for the triple antiretroviral mothers, and then postpartum, again, randomization of the mothers, either to triple ARV or else infant nevirapine. 942 children enrolled between 9 to 12 months of age. Of those, about half were unexposed, uninfected, enrolled from those communities. About half were girls, and about half were either Ugandan or Malawian. Why the Mullen scales? It's a lot like the Bailey scales, which is considered by many the gold standard of neurodevelopmental assessment, but easier to adapt in our view within resource-constrained settings, and one that we'd used quite a bit already in prior work in Uganda in particular. Why the Kaufman assessment battery at 48 and 60 months of age? Again, one that I had been using even during my Fulbright year in 1990. Now it's been used in a dozen different African countries in looking at neurodevelopmental assessment outcomes for at-risk children. So we felt that we had a good comparison source of data to know how our children in PROMISE were doing. But we had a feature of this study which I want to emphasize how important this was. It was a quality assurance protocol whereby each of our testers submitted a videotape of their assessments, whether it be the Mullen or the Kaufman, on a monthly basis. And we had an assessment team of expert, very experienced testers at our Macquarie University, Johns Hopkins University, Kampala study site, who reviewed those assessments and provided feedback to each of our testers at both sites, both for the Mullen and for the KBC. Okay, this is our reference group, unexposed, uninfected. On the left-hand side is Malawi, on the right-hand side Uganda. Top graphs are at 12 months, bottom graphs are at 24 months. These are box plots, so that you see the median bisecting a box. The top is the third quartile, bottom is the first quartile, and then a range of scores with outliers also individually plotted. These are your most exposed triple antiretroviral, both antepartum and postpartum. And then the other groups represented here are your other combinations within that randomized controlled trial for the PROMISE study. And just glancing at these, you can see that all the groups are pretty comparable at both study sites at both 12 and 24 months in terms of the distribution of their performance measures. Here's at 48 months now. Left side's Malawi, right side's Uganda, 48 months on the Mullen. On the bottom, we see the adjusted mean scores. But again, looking at the most exposed group to the highly active antiretroviral scheme, they look very similar. Now with the Kaufman battery, and for both sites combined, 48 months on the left, 60 months on the right. There's our reference group, unexposed, uninfected. These are our highly exposed group to the antiretroviral treatment combinations. And again, very comparable. And if we look at their adjusted means for the reference group compared to the highly exposed group, and you look on the far right-hand side, no significant differences in our analysis of covariance, either for all the major domains of the KBC, these various neurocognitive domains like memory, visual spatial processing, learning, a nonverbal index, as well as a comprehensive mental processing index, kind of like an overall cognitive ability score. And then at the bottom, at 12, 24, and 48 months, are cognitive composite scores for the Mullen scales of early learning. And again, no significant differences among those groups. And in fact, for these unadjusted means, the maternal triple antiretroviral treatment combination, those kids do actually just as well, if not better, than the other treatment arm combinations. So how to interpret and what our conclusions are? Basically, good news. And the good news is that antiretroviral, triple antiretroviral, both pre and postpartum, doesn't seem to pose significant developmental risk to these children in this setting. In fact, they may be doing better than were we not to engage in full triple antiretroviral, both during gestation as well as postpartum, which of course is now the standard of care. But what was related was stunting or growth. It turns out that although our children were at risk below the WHO norms in terms of height for age adjusted Z-scores, they were less stunted than the other treatment combinations, which didn't involve highly active antiretrovirals. In fact, there was a significant difference here in terms of their baseline growth scores at both 24, 48 months for those kids. And growth was significantly related to the composite cognitive score on the Mullen across all assessment points. Receptive language in particular seemed to be sensitive to this dimension of development. For our exposed kids especially, as well as comprehensive cognitive performance as measured by the Kaufman battery. So let's back up a minute. So what is happening here in terms of exposed versus unexposed kids? Because there's been a lot of talk, even at a pre-conference seminar on exposed and unexposed children and adolescents at the last Friday and Saturday, the 2 days workshop on pediatric HIV, the 10th annual workshop on that. We're not finding differences overall between exposed and unexposed. Botswana, 2 years ago I presented at a discussion poster with their exposed, unexposed preliminary findings, which had since been published. They didn't find any differences. And this was another very large clinical trial comparing exposed to unexposed. And then most recently, they published their data in the journal AIDS some months back now, comparing AAA antiretroviral to zidovudine during pregnancy, and didn't find any differences either. Though South African Cape Town has reported differences using their measures, as well as Western Kenya. So we've got inconsistent findings, and I want to propose that really important in comparing this, making this kind of comparison, just how at risk are these exposed children, you have to have equivalent unexposed, uninfected reference groups. You've got to make really sure you're comparing apples to apples and not apples to oranges, so to speak. That means a good standard of care for the mothers that are on triple antiretroviral, that they're adherent, that they're virally suppressed, and if they're doing well medically, they're going to be doing better in terms of mental health, in my view. That was an earlier seminar today that mental health interventions for mothers and at-risk women. Quality of caregiving, then, for these children in these early months and early years is going to be better if the moms are healthier and more functional, which I propose they will be on triple antiretrovirals throughout, and good adherence. The quality of nutrition, because so much depends on these moms for the well-being of their children, nutritionally and in other terms of caregiving. And then making sure that your comparison groups of exposed to unexposed are equivalent in terms of the very risk factors that we've been talking about at this meeting that make women vulnerable to HIV infection in sub-Saharan Africa. Breastfeeding, that proved to be a really significant factor. Now in our Ugandan, about half of our various exposed treatment combination groups were breastfeeding about by 1 year of age for the children, and the median for the unexposed is about 87%. The vast majority of our Malawian moms were breastfeeding, so we didn't have enough that were not breastfeeding for a good comparison. But breastfeeding at all of our assessment points was significantly related to our neurodevelopmental and neurocognitive outcomes. So it's going to be really important consideration in the way of interventions going forward. So this is from that Lancet 2016, an overall model within which I'll frame our findings that, sure, there's some risk involved gestationally from various comorbidities for the pregnant mom, but overshadowing those is the mental health and the medical health and functionality of the mom. One good example is maternal depression. That'll impact on quality of caregiving. And if we can intervene, providing good mental health, good medical support for the moms, even early childhood development training, which is something that was talked about at a Sunday morning symposium here as part of a pre-conference activity. And we've been doing that over the last 10 years in an impoverished area of eastern Uganda, clinical trials on an early caregiving development, child development training program for the moms. And we found that as we improve quality of caregiving for these mothers with HIV, in combination with good treatment and support, that their children will do a lot better developmentally. So functionality as it relates to health, as it relates to treatment, medical support, and mental health treatment and support are going to be really important for these kids in terms of their long-term prospects and whether, in fact, they will be less at risk over the long term than their unexposed, uninfected counterparts in the sub-Sahara. A great big thank you to our Malawi and our Ugandan team here on the beautiful shores of Lake Victoria at Manyonyo during one of our annual retreats, and some of whom are here in this audience today. A big thank you for making this possible. Thank you.
Thank you very much, Michael. In the interest of time, we will now move on to our second presenter. Please join me, and I now invite Lisa to make her presentation. Lisa is a third-year PhD student. In her research, she tries to integrate the field of psychiatry and internal medicine. So she's going to tell us about CNS toxicity of efavirenz in children in Tanzania. Lisa, over to you.
Well, thank you very much for letting me present our work at AIDS today. And this work is actually the result of a collaboration between Radboud University Medical Center in the Netherlands and KCMC KCRI in Moshi, Tanzania. And on behalf of the whole team, I would like to say that we have no conflicts of interest to disclose. Well, let me continue with the main topic of this talk, which is efavirenz. And as you all know, efavirenz is actually part of the former WHO preferred first-line treatment regimens for adults, but also for children. And efavirenz has several advantages, such as a good antiviral potency and its availability in generic combination tablets. But most of you will also know that efavirenz is known for its neuropsychiatric side effects. And roughly 1/3 of adults report symptoms. And these two papers, which are shown on this slide, actually nicely illustrate that the debate on these side effects is still lively and ongoing, as they are both have been published in high-impact journals within the last few months. We wanted to focus on children, and we first performed an extensive search and identified two papers that used a validated tool to assess neuropsychiatric symptoms in children. And there was one RCT that found no differences in scores in 4-year-olds on efavirenz versus lopinavir. And the other study, which was an observational study among adolescents, actually found favorable scores in the efavirenz group compared to the controls. On the other hand, case reports have been published describing severe effects such as seizures, but also psychosis. And the remaining studies, which include both trials and observational studies, report largely inconclusive results, which is probably due to the fact that these were primarily designed, or not primarily designed, I have to say, for the assessment of neuropsychiatric functioning in children. However, you can imagine that nowadays children with HIV survive into adulthood, and that mental health and development are crucial for their future perspectives. So we designed a cross-sectional study, and we, first of all, wanted to focus on behavior and emotion. And there we distinguish, on the one hand, competence, which is the result of school performance, but also engagement in social activities and other activities. And on the other hand, we looked at psychopathology, and you can distinguish, on the one hand, internalizing problems, which are mostly characterized by internal distress, anxiety, depression, and externalizing problems, which are more characterized by rule-breaking behavior. And we assess this using the Child Behavior Checklist, which is a 100-item extensive questionnaire available in Kiswahili and validated in Sub-Saharan Africa. Second, we wanted to look at cognitive performance, and we specifically assessed intelligence and memory. And last but not least, we looked at adherence using one of the adherence penta questionnaires. So in total, we analyzed 141 children, which were recruited from 6 study sites in Kilimanjaro region in Tanzania. And these children were aged between 6 and 12 years. They had received treatment for at least 6 months without a recent treatment switch, and they had viral loads below 1,000 in the past year. They also had to be in the presence of a caretaker who was part of the upbringing of the child. And children who presented with any acute illnesses or any pre-existing developmental delay were excluded from participation. In total, we had 72 children on efavirenz and 69 children on a non-efavirenz containing regimen, which was further divided into 26 children on lopinavir and 43 children on nevirapine. So in general, children were roughly 9.5 years and 50% was female, and this did not differ between groups. They also did not differ in nutritional status, neither in socioeconomic status, and about 75% of children was virologically suppressed in a sense that they had viral loads below 40 copies per ml, and this did not differ between groups. We did, however, identify some important differences between groups, which is that the control group used treatment for a lot longer time. They had more often been admitted to the hospital, and they had also more often experienced treatment failure. While the efavirenz group had more often been treated for TB, and for whatever reason had more often been disclosed with their own HIV status, as well as lost their parents, one or both. So in general, when comparing our group to age, sex, and Kenyan population-specific norms, we found that 25% of our group scored below the normal cutoff for competence, and that although psychopathology wasn't even that common in our population, almost 30% of children presented with internalizing problems above the normal cutoff. When we then focused on group differences, we found that children in the efavirenz group scored significantly lower for competence, which was primarily driven by lower school performance scores. And although we did not see any differences in psychopathology, we did observe consistent trends towards more problems in the efavirenz treated group, which held true for total internalizing thought and attention problems. Secondly, we assessed neurocognitive performance and adherence, and we did not see any differences there. And lastly, we did an exploratory analysis for central nervous system symptoms that have been mentioned in literature using a checklist, and we found that after correction for multiple testing, the efavirenz treated children had more attention problems at school. And I forgot to mention that, but of course, due to the group differences in clinical characteristics, we adjusted for these differences in our models. So after data collection, we found out that if we compare the dosages that the children in our group would be prescribed, that a substantial number of children actually received doses that were below the WHO 2016 recommended doses. And these children did not differ from the other efavirenz treated children in any general characteristics, and we could not identify any specific reasons in the file. But we did want to assess whether underdosing had affected our results, so we repeated the analysis after excluding this group. And in line with our previous result, we observed lower competence scores in these efavirenz treated children, but now we also observed significantly increased psychopathology scores, which held true for the different problems, mostly internalizing problems. And in line with the previous results, we did not see any differences in cognitive performance or adherence. So in conclusion, I would like to say that in our study population, efavirenz was associated with a mild increase of neuropsychiatric symptoms, and most strikingly the lower school performance scores, even though groups seemed equally intelligent and there were no differences in memory. These effects were more pronounced in children who received doses that were at least equal to the WHO 2016 recommended doses. And I think it's important to note that we, of course, don't know how these symptoms are going to develop, especially not during transitional periods such as adolescence or adulthood. We have to, of course, acknowledge certain limitations. So our cross-sectional design, due to that design, it's impossible to draw any conclusions on causality. And there were substantial group differences, but as I mentioned, we tried to correct for that. In general or overall, the control group seemed to be more severely affected, so it is possible that we underestimated the effect of efavirenz. We also don't have any data on CD4 counts, plasma levels, or genetics, and cannot draw any specific conclusions on exposure. But in conclusion, I would like to say that our data support the WHO guideline switch to dolutegravir. And in the meantime, clinical awareness is needed. And I would finally like to emphasize that this should also be a good possibility for more nice and detailed follow-up studies, switch studies, in which efavirenz can be compared to dolutegravir. Of course, I did not do the study on my own. We have a whole multidisciplinary and international team. And this was the end of my presentation. Here it is.
Thank you very much, Lisa, for that great presentation. I'm sure everybody now is feeling a little more warmer, knowing that it is indeed true we have challenges with efavirenz and school-going children. We have 3 minutes. We'll take just 2 questions because we have eaten into our time. Yes. Yes. Okay, that's mic number 1.
Pablo Rojo from Madrid, Spain. Very nice presentation. So we did some studies related to efavirenz effect on neurocognitive evaluation, and we saw that these children have sleep disturbances. Mm-hmm. So we thought that maybe the school performance in our children could be related. So have you studied the sleep performance?
No, I would be eager to discuss that. We did not examine any language-related intellectual capacity because we did not have the tools for the Kiswahili assessments. But it would be nice to, I would be eager to hear your results.
To see the sleep profile.
Sleep, oh.
Yes.
Sleep.
Well, actually, I thought language, sorry. Well, we asked for sleep-related symptoms, of course, because efavirenz is known for nightmares. But in these children, we did not observe an increase of nightmares or any sleep-related disorders, probably due to the fact that the children in our population used efavirenz for an average of 3.5 years. And these effects are thought to be most prevalent within the first weeks and then slowly disappear. But that was striking as well.
All right, one more question, Bovin.
Yeah, Lisa, one of our lead co-investigators on the PROMISE study, Dr. Itziar Familiar, has published work from Uganda relating maternal depression as measured with the Hopkins Symptoms Checklist to internalizing symptoms with the Achenbach Child Behavior Checklist. And in fact, it was really strong among children with HIV. We saw the same effect using the brief, another caregiver rating inventory. Yeah. Is it possible that at least some of the problems you're seeing with the children depends on maternal depression, which in turn depends on treatment failure with efavirenz, which seem to be pretty high in that group?
Well, thank you for your note. Well, with the data that I have, I would not be able to either refute or accept that theory. I can imagine that it happens. Also, a previous study in Tanzania assessed. But it is well possible. I can't say it isn't. Yeah.
All right, we'll take one last one, and then we move on. In the middle.
Caroline Foster from London. Thanks for a great presentation. This is related to Pablo's question, really.
Yes.
Were all the kids taking their treatment in the evening?
Sorry?
Were all the children taking their antiretroviral therapy in the evening, or were any of them taking it before going to school?
No, so it's difficult for me to say all children were taking it, but the policy of the nurses was that they advised children and parents to take tablets in the evening. But I cannot say for sure whether that in fact happened.
Okay, thanks.
Yeah.
All right, join me to thank Lisa, and thank you very much, Lisa.
Our next presenter is Dr. Dalton Wamarwa, who is a senior pediatrician from the University of Nairobi and Kenyatta National Hospital. He's a principal investigator and coordinator of the Living Study in Kenya, and he's going to talk to us about evolution of viral suppression across different age groups in the Living Study. Welcome, Dalton.
Thank you very much. It's a privilege to present on behalf of the Living Study Group the results of our study on pellets formulation of lopinavir, ritonavir. It's a large group from Kenya, Uganda, Tanzania, and supported by DNDi. Now, lopinavir, ritonavir has been a very important drug for us for children. However, there are challenges, including the fact that the syrup has a bitter taste. That's a problem for the younger children. It's also not heat stable and requires refrigeration. So once dispensed, it can only stay out for about 6 weeks. The tablets, on the other hand, which can be taken for children above 10 kilos, also come with a caveat. You cannot, must be swallowed whole. They cannot be crushed or broken or chewed or dissolved before administration. So if a child is not able to take them whole, then they're not suitable for that child. Now this brings me to the pellets, and you can see over there it said that the pellets are in a capsule that the caregiver opens and gives with a small amount of food. These are test masked, they're stable at room temperature, they require no refrigeration, and they're relatively easy to administer with a small amount of food. It's also not difficult to compute the dose or monitor adherence. Now, the pellets have received FDA approval in 2015 for use in infants and young children and have been incorporated into the WHO guidelines. However, there's little clinical data on effectiveness and safety in routine care. Our study objective was to evaluate the effectiveness, safety, PK, and acceptability of the lopinavir ritonavir pellets given together with the ABC 3TC or AZT 3TC dispersible tablets in routine care conditions in HIV-infected infants and young children who cannot swallow the tablets. As shown in this map, this study is being conducted in 3 East African countries, Kenya, Uganda, and Tanzania. It's a single-arm phase 3B pragmatic study, open-label, prospective, non-randomized, a multi-center, and we use a WHO weight band dosing. We included children who were HIV infected between the age of between the weight of 3 and 25 kilos. Age was not a criteria. These children could either be ART naive or already on the first-line liquid formulation of lopinavir, or they could also be children who are failing the NNRTI-based therapy, and they will be unable to swallow tablets. Children who had planned use of NNRTI, so other classes such as INSTI were excluded. So were those with the treatment that significantly interacts with lopinavir, such as those on anti-TBs. Children with significant disease that would compromise participation, any contraindication to PIs, recent use of experimental drugs, and those who we anticipated transfer from the study site. Those were excluded. Now here we show the status as of April of this year. Kenya had 5 sites with 443 children, Uganda 5 sites with 350, and Tanzania, which started recruiting slightly later with 2 sites, 154 children with a total of 947 children. Out of the 947 children, the majority were ARV experienced, about 90%. And in fact, most of these children were taking the liquid form of lopinavir, ritonavir. Just about 10% of the children were antiretroviral naive. By month 3, that's about 3/4 of the cohort had completed that visit, and just under half, 45%, had completed the month 12 visits. These are the children we are focusing on today, those who had completed the month 12 visit and had a complete set of CD4 and viral load. Here's a summary of the baseline characteristics for this cohort, stratified by prior ART. So we have the 3 groups, ARV naive, those who were on lopinavir, and those who were on NNRTIs at baseline. Although the median age for the whole cohort is 42 months, you'll note that the naive children were much younger, and as you would expect, they had a much higher viral load of 5.4 log. And those who are failing NNRTIs also had significant viral load of 4.7. But it's interesting to note also that even those children on lopinavir had log 2 of viral load. Retention in this cohort has been good, with more than 90% retention at both 24 weeks and 48 weeks. Now, this is a key slide that shows virus suppression, categorized here by ARV exposure. And as you would expect, the naive children, a very drastic drop in viral load in the first 24 weeks from 5 to 2 log. And also the last figure, those who are failing NNRTI, also a drastic drop. But it's important to note that even those children who are on lopinavir syrup still experience substantial drop of about 0.5 log in viral load between baseline and 24 weeks, and this was maintained to 48 weeks. Now here we're looking at viral load stratified by the age of the child at enrollment, categorized into 4 groups, 5 to 11 months, again significant drop in viral load, 12 to 24 the same, and all the way to the 25 to 48 and children above 48 months. In a nutshell, we're seeing virus suppression across the 4 age categories. Now here we look at viral load as a proportion with a cutoff of 400 copies per mil. And just looking at the table, naive children, as you would expect at baseline, very few of them with suppression, just under 10%, and this goes up to 69% at week 24 and 72% at week 48. Those children who are on lopinavir, the liquid formulation, started off about 62% virally suppressed, and this increased significantly. By 24 weeks, it was 79%, and by week 48, 80% of the children had a suppression below 400. The group of the NNRTI also had significant suppression, as you've shown. This is illustrated in those line graphs. Again, looking at the virus suppression, stratified by duration of prior ART, similar findings. Children who had been on ART for less than 6 months, viral load dropping quite markedly. And all the other categories, 6 to 12 months, 12 to 24, and above 24. Similarly, we are seeing drop in viral load. Now here we look at immune reconstitution, and on the y-axis is the proportion of children who would meet the WHO criteria for severe immunodeficiency, and this is categorized by age. So we're seeing that across the time from baseline to 48 weeks, fewer and fewer children remain severely immunosuppressed. This is more so for the children who are the younger ones, but it's seen across the board. So immune reconstitution happening. Looking at the anthropometric parameters, two measures here, weight for age, Z-score, and weight for length, Z-score. Here, children categorized by prior ART. Very significant increments in weight for age for the naive, but also similarly for the children who are on lopinavir and those on, who are on NNRTI at baseline. A similar trend is seen in the weight for length. In terms of adherence, this is the measured adherence by pill counts. Consistently, we report this study found high adherence as shown. Now, there were some adverse effects, as you'd expect. And just pointing out the adverse events, these are conditions really which are common in children in these settings: respiratory tract infection, diarrhea, upper respiratory tract, skin conditions, as well as malaria. Some of our sites are in malaria endemic areas. And serious adverse events, again, seen in 25 participants. These include gastroenteritis, malaria, pneumonia, malnutrition, and those listed. So in conclusion, this interim analysis shows that treatment with the lopinavir-ritonavir pellets was associated with satisfactory levels of virus suppression, regardless of prior ART regimen. Children experienced good CD4 reconstitution and anthropometric improvement, and the pellets were effective and well tolerated with minimal safety concerns. Like to, so the steps that are left, one is to complete follow-up in the site and conduct the PK analysis, as well as HIV drug resistance in those children who will be viremic at 24 and 48 weeks post-treatment initiation. I'd like to acknowledge the children and caregivers who are participating in the study. We've received support from the Ministry of Health in the 3 countries and DNDi staff, both in Nairobi and Geneva, and we have many of them in this audience. As I said, it's a large partnership with all those institutions, and special acknowledgement to AFD, MSF, and Unitaid for this funding. Thank you.
We'll take 2-3 questions. 3 questions. Mike, go ahead.
Thanks very much. I'm Graham Mankis from South Africa. Just interested, the improvement in viral suppression from 62 to 80% when switching from the lopinavir-ritonavir syrup to the pellets is very impressive. Do you think that's all just due to the change in formulation, or was it perhaps improved adherence support in the context of a study that they weren't receiving prior to the study?
Thank you for the question. We think that the formulation played a significant role because, especially, we did also qualitative work on the side, and a lot of children were experiencing spitting, vomiting prior to switching to the pellets, and this improved. There wasn't much difference in the way the children were being monitored or followed before or after. Indeed, some of the children had been on different studies before. Yeah, thank you.
Any other question? Okay, looks like it was very clear. Thank you, Dalton. Our next presenter is Dr. Mark Cotton, who is the head of Division of Pediatric Infectious Disease and Director of the Family Infectious Disease Clinic at Takeback Children's Hospital, Stellenbosch University in South Africa. He's going to talk to us about another PK studies. Mark Cotton, you're welcome.
Yeah. Thank you very much. So I'm going to talk about the pharmacokinetic safety and efficacy of bictegravir, emtricitabine, tenofovir, alafenamide, or TAF single-dose regimen for children between 6 and less than 12 years of age. These are my disclosures. And then to start off with, firstly, to thank all of the participants and their families and the study personnel at all of the sites. So the introduction then, bictegravir or BIC is a new unboosted integrase strand transfer inhibitor. It has very low drug-drug interaction potential. It's co-formulated with FTC and TAF, single tablet once daily, and without regard to food. It's already approved for adults in most of the developed world, and this is after 4 phase 3 studies showing high rates of viral suppression and no treatment emergent resistance to any of the components. It's well known that TAF has improved bone and renal safety compared to tenofovir disoproxil fumarate or TDF, and also the PK safety and efficacy of this formulation in adolescents is similar to that of an adult, and we now report on these parameters in virologically suppressed children. So the primary aim was to determine the plasma PK of BIC and evaluate its safety and tolerability of the regimen through 24 weeks of treatment. And then the secondary was to evaluate safety and tolerability through 48 weeks and also antiviral activity at weeks 24 and 48. So this was the study design. The eligibility criteria, again, we've mentioned the age and weighing more than 25 kilograms, being virally suppressed, that's less than 50 copies for more than or equal to 6 months, CD4 above 200, and an estimated GFR greater than 90. This was a phase 2-3 open label, multi-center, multi-cohort, one-arm study. Part A was intensive PK, and that was to confirm the dosage. And Part B was a follow-up with including new recruitment for 48 weeks to look at short-term safety. And this was after an independent data safety monitoring review. So for the PK, intensive PK, and this was at steady state, weeks 2 or 4, looking at exposures of BIC as well as FTC and TAF. And the comparison was with adults' reference ranges. And the method used was the percentage geometric least squares mean ratio with a 90% confidence interval for the 3 drugs. And the predefined equivalence boundaries were between 70 and 143% of adult values. The safety assessments were standard, adverse events and lab abnormalities, efficacy, viral load and CD4, and the tablets were also assessed for acceptability and palatability using age-appropriate questionnaires. And then adherence was a measure of drug taken versus drug dispensed. So looking at the disposition, firstly, for Part A, the intensive phase, 27 children were screened and 25 enrolled. There was then an IDMC evaluation of the PK data, and approval was given to proceed with Part B on the basis of the data that they saw. So Part B, 31 patients were screened and 25 enrolled, and for both Parts A and B, the enrollment went quite quickly. So the total in this cohort was 50, and none discontinued and are all on the study drug. Looking at the baseline characteristics, firstly, the median age was 10. You can see a nice range between 6 and 11. A good weight of 29. Females slightly more than males. And in terms of the race, a fairly good spread across the races, with the majority being black children, also some Asian and white. In terms of countries, again, good enrollment in the 4 countries. South Africa had slightly more, but also well represented in USA, Thailand, and Uganda. The CD4 count, the mean was 930 cells, and the estimated GFR was 153.5. And the time since diagnosis of HIV was a median of 10 years and ranged between 2 and 11 years. Looking at prior ARV treatment before the switch, you can see for NRTIs, the majority was idovudine 3TC, followed by Bacavir and 3TC, and a small number were actually on fixed-dose combinations taken twice daily. For the third agent, the PI was usually lopinavir ritonavir was more common than the NNRTI, and then a small number were already on integrase strand inhibitors. So now looking at the intensive PK and the main objective of the study, looking at the area under the curve over time, that's between dosages, 24 hours, looking at the ratio of children to adults. In the last column, you can see that they were fairly equivalent. Looking at the Cmax, it was a bit higher than for adults, but with the ratio within acceptable limits. And looking at the lowest concentration over the dosage interval, it was lower in children than in adults, but also the ratio being acceptable. In terms of the high Cmax, no exposure safety issues were noted. And looking at the lowest concentration, that level was 14 times higher than the protein-adjusted effective concentration. So it was still a more than acceptable concentration. Looking at the other components, firstly the FTC, what you can see is that both the area under the curve, the Cmax, and in fact also the lowest concentration were higher than adults. The GMR was slightly higher for area under the curve and Cmax, and equivalent but slightly lower for the lowest level. For TAF, again, the exposures, area under the curve was a bit higher, and the Cmax was also a bit higher, and you can see the percentage GMR at 175 for area under the curve and 170 for the Cmin. However, these values for FTC and TAF were consistent with historical data from adults, adolescents, and children using FTC TAF products, including the elvitegravir, cobikistat, Genvoya. Looking at overall safety, firstly, this was over 33.6 weeks of evaluation. You can see that there were, as always, adverse events, most common of which were upper respiratory tract infections, and none were grade 3 or 4, none were serious, no one discontinued, no deaths. And in terms of adverse events related to the drug, there were 6, And you can see a list, one each: abdominal discomfort, diarrhea, fatigue, increased, decreased appetite, dizziness, headache, and rash. Grade 3-4 lab abnormalities were very uncommon. There were 4 that resolved fairly very easily. In terms of changes in the estimated GFR, at the end of the study period, it was -11, and that's in keeping with competing with creatinine for tubular secretion. So your serum creatinine actually rises because of that. So again, this is a known effect and is not considered clinically significant. In terms of virologic outcome, and you can see that the children remain suppressed. The CD4 counts remained essentially unchanged, and this was a snapshot analysis at week 24 and involved 25 of the 50 participants in the study. None needed resistant studies. In terms of adherence and participant-reported palatability and acceptability, all regarded the combination as palatable with an acceptable shape and size. The adherence on the whole was excellent. Median was 98.8%. So conclusions, again, children between 6 and less than 12 years weighing more than or equal to 25 kilograms. The exposures of the 3 components, BIC, FTC, and TAF, were consistent with what was seen in adults in phase 3 trials. It was well tolerated, good rates of virologic suppression, and the efficacy and safety were again consistent with earlier data. So the data from this study suggests that this could be a treatment option for children and supports further investigations with age-appropriate formulations for younger children. Thank you very much.
Thank you, Mark. We will take some questions. Questions, please.
Thank you very much, Mark. Now, the Cmax was higher than the adult. What is your comment? How did you deal with that?
Yeah, we're talking about the TAF. Yes. That seems within the range of what's accepted. Also, TAF is in fact metabolized, and its actual exposure is far less and for far less time than tenofovir disoproxil. So it's not considered an issue at all. Although this is short-term data and more follow-up, is necessary.
Yes, Mike on the left. Go ahead.
Pablo Rojo. Mark, fantastic data. You think we could go even a little bit down to 20 kilos with these data? I mean, doing studies with the same tablet? Because...
yes, look, I'm not sure. And it's also not up to me. But of course, it would be great if we could. I think, one does worry about the higher exposures anyway. It's, in a lower weight band. And I think one would have to be a bit cautious, although it sounds like a good idea.
Thank you, because I was thinking of course, this could also inform for the TAF for these children, even not combined with bictegravir, I suppose. So it would be interesting, the combination for countries that could not yet afford bictegravir, but maybe with dolutegravir, don't you think?
I think that's a great thought, and of course we would love more access in our part of the world, where HIV is very common.
Yes, go ahead. The lady.
Yeah, it's along with the question of Pablo. Did you break up your number like the 6 to 9 versus 9 to 12 or to the 25 to 30 kilos to kind of see if the higher Cmax were in the younger and lighter kids?
I think that's a great question. To my knowledge, it was not done, but I think it's well worth doing. Thank you.
Next.
Regarding the diminution in the eGFR, I wanted to ask if you have also evaluated markers of renal tubular damage as it is associated with TAF.
Yes. So what I know is that formal glomerular filtration rates have been measured, and not using not the estimated one, and they have proven to be fine in other studies, not in this study. So, to my knowledge, this was not evaluated in any other way with any other markers of renal toxicity. But I also think that's it's a good thought.
And did you measure the filtrate with some other marker that is not the
a urinary marker of renal damage?
Yes.
Not to my knowledge, and I think that it's a good thought, and I think the sponsor, I'm sure, will take note of that. Thank you.
Thank you very much. Thank you, Mark. Our last presenter is Dr. Florence Buzian. I hope I got that right. She's a PhD in microbiology, working at the Institut Pasteur in Paris, and she's going to talk to us about the immune studies in children and adolescents in collaboration with the French National Cohort. Florence, you have the floor.
Thank you. First, I would like to thank the organizer for giving me to present for the first time the data from the CLICK study. CLICK is an acronym for comparisons of late versus early antiretroviral therapy in children. As a background, we now know that early combination therapy initiation decreases mortality as compared to deferred treatment. It has also been shown that early ART results in a lower blood viral reservoir, and this has been demonstrated in infancy and early childhood, as well as in a subset of children and adolescents, but only those with a sustained virological success have been studied so far. Early ART results in higher CD4 levels, but the persistence of this benefit has been questioned in children with longer treatment durations. We all know that lifelong ART is a challenge, and this raised a series of questions. Regarding the benefits related to early ART, will this benefit persist until late childhood and adolescence? Will the benefit persist if viral replication resumes? And this early treatment established a beneficial virus-host equilibrium. And this equilibrium will have certain specificities that are related to infection in the perinatal period. So, through the study of these early treated patients, can we draw some lessons that would help us to design future therapeutic strategies in pediatric patients? So, the CLICK study aims to provide new information on these questions. First, we focused on the medium and long-term benefits of combination therapy, and we have included children between 5 and 12 years of age, as well as adolescents between 13 and 17 years. All these patients have an initial virological control, but this control may be sustained or not until the time of the study, because we wanted to catch, let's say, real-life patients. And third, this is a pathophysiological studies, and we have assessed immune and virological markers. So this studies is a cross-sectional studies, and it's partly nested in the prospective French national cohort. And the objective is to compare immunological and virological characteristics between HIV-1 infected children with early versus late initiation of treatment. In this study, we have defined early treatment as an initiation before the age of 6 months and late as an initiation after the age of 24 months. Inclusion criteria are HIV infection in the perinatal period, being between 5 and 17 years at infections, and an HIV diagnosis before the age of 13. All the patients have to be on ART at least once, with early or late ART initiations, and an initial virological success defined as an HIV RNA below 500 copies, which within 24 months of initiation. The study designs, all these patients are followed up at clinical sites within the Paris area, and if they fulfill the inclusion criteria and accept to participate to the study, we draw 2 blood samples for them, and we perform a series of immune and virological assessments, and a third visit is planned for a detailed study of the reservoir for some of them. So, regarding the timing of this project, the inclusions were completed 4 months ago, and all first visits were completed exactly 3 weeks ago. So today I will present you preliminary data on 72 patients and on 2 outcomes, the total blood HIV-1 DNA and the naive CD4 and CD8 T cell levels. So a few words about these outcomes. The total blood HIV DNA load is a clinically relevant marker of the viral reservoir, and it was quantified by an ultrasensitive quantitative PCR assays. Among T lymphocytes, the naive ones are very important because these are the ones that will answer to a new antigenic challenge, which means they will provide protections against pathogens, vaccines, or tumor cells. They were quantified in fresh whole blood samples with a flow cell cytometry method. For analysis, we compare our 4 groups of early or late treated children and adolescents with a Kruskal-Wallis test, and for multivariate analysis, we have performed median regression. So, who are the patients included? Among children, 24 received early treatments at the median age of 2 months, and 19 were late treated, and their median age at initiations was 54 months. For adolescents, 8 received early treatments. The median age was 2 months. And late-treated adolescents initiated their treatment at 90 months. The sex-to-female ratio is well-balanced, and 74% of the patients were of sub-Saharan Africa. Around 60% were born in mainland France, and this proportion is, however, lower for those of the 2 late groups. At the time of evaluations, median age were 9 or 8 years for children and 15 or 14 years for adolescents. All patients were on ART. The rate of virological suppression was around 90% for children and lower for adolescents, 63 or 76%. All groups have elevated CD4 T cell counts with a median above 800. So the first outcome, our data clearly show lower HIV-1 DNA level in the 2 groups of early treated patients, children and adolescents. Indeed, medians were 2.2 log for early treated children versus 2.9 for late treated. For adolescents, we have similar figures of 2.3 and 3 logs in early and late treated adolescents. Another point that should be noted is the wide range of HIV DNA in the 2 early treated groups. For the multivariate analysis, we included the detection of HIV-1 RNA at the time of the study and the geographic origins. And this model showed that the total HIV-1 DNA levels were independently associated with age at initiation of combination therapy and the HIV RNA level at the time of the study. Regarding the immune marker, on the left panel you have a CD4 naive cells, and on the right one the CD8 naive cells. For both markers, the highest levels were observed in the early treated children. And the difference are modest for naive CD4 and more marked for naive CD8 cells. We found no difference between early and late treated adolescents. However, the data from the adolescent groups required cautious interpretations because these two markers are affected by viral replication, and this is an issue in adolescents. And we have only preliminary data on 58 subjects so far. As a discussion, I will show you a summary slides proposed by Véronica Bétan-Fénoël that shows the total HIV-1 DNA levels that have been quantified with the same assay in the same laboratory for pediatric and adult patients followed in France. In red, you have patients with natural infections, both adults and children, with a median range around 3 logs. In light blue, these are the patients who started their combination therapy during primary infections. The median are really similar for adults and children and adolescents from the CLIC studies, around 2.2. For patients who started out during chronic infections, so the levels are, of course, higher, but they are, once again, very similar between adults and children from the CLIC studies. Finally, on the left part, in green, you have data from adults with a spontaneous control of viral replications, the HIV controller and post-treatment controllers. These have lower DNA levels, and what gives us hope is the fact that some of the early treated children and adolescents have a DNA level as low as those of these adults with a spontaneous control of infection. As a conclusion, our preliminary data shows that early combination therapy during infancy was associated with a lower HIV-1 DNA level in children older than 5 and adolescents. Our data also support a possible immunological benefits of early combination initiations, and we have investigation plans to now define the factors that impact the viral reservoir and the T-cell restoration. I would like to thank all the members of this study, and more especially Pierre Franche, who was the coordinator of the studies. I want to thank all the investigators, our sponsor, and the patients and their family, and I want to thank you for your attention.
Thank you, Florence. We'll take some questions. Yeah, please go ahead.
Yeah, Florence? Am I on? Hello. So we compared subtypes A and D in treatment-naive Ugandan children, subtype A being already having CCR5 receptor tropism, and then subtype D and CXCR4, and found a big neurodevelopmental difference by the time they reach school age. With testing. But then we looked, in a follow-up study, we looked at children who were treated in the first year of life with antiretrovirals, and both at preschool with the Mullen and then later school age with the Kaufman and other tests, those differences between subtypes disappeared. Now, in your sample, 72 children, I mean, they come from Europe, from sub-Saharan Africa, a lot of different subtypes represented. Is that in a consideration in terms of this kind of work, in terms of the impact of early treatment? Could it be modified by subtype?
It's possible. So the determination of HIV subtypes are really planned, and they are expected to be very diverse based on what we know. We have not yet performed this analysis. And what we expect is not major difference in children who benefited from early art, but maybe differences in the late treated children and adolescents.
Any other question?
Yes, Mark. I think your early art was less than 6 months. The early antiretroviral was less than 6 months, starting at an age of under 6 months.
Yes, it was.
Yes. So have you been able to look at that group more carefully For example, we have shown that by 12 weeks of age, about 60 to 70% of the infants are in bad condition already because of, advanced disease. And possibly there would be even bigger differences if you could discriminate your early treatment group more finely.
Yes, certainly. So this is a big frustration of the presentation of preliminary data. I cannot answer your questions, but this is planned to analyze more precisely the data according to the age at initiation. And it's also important to notice that the early treated patients were all born in France, so they may have progressed more slowly than in Africa, but this has to be investigated carefully.
Do you have a question?
No, I don't have a question. We are just in time. Allow me to thank our presenters who have given us a variety of different things, ART strategies, ART outcomes, and immunology. Give them a clap, please. I want to invite you to the next session for children, which is in the forum. I want you back. And we want to thank all of you for being patient and being those who have contributed questions. We can't thank you more. Thank you very much.